You've done a fair few of these now, so are there any clinical history or physical exam signs that you have that you now think this tendinopathy is one that's more likely to respond to PRP? How do you decide who to physio, who to inject?
Yeah, so look, I think that's a really good question, and obviously there's a lot of decision making that goes into your clinical decision to perform a certain treatment or not. Yeah, so I guess it really depends on the patient is the first thing. I think if people have a really, really strong pain response, so, night pain, pain that's stopping all their activity, I'm almost more inclined to go with cortisone first because I'm actually just trying to help them, and I can guarantee them if I give them a PRP injection, I'll make their pain worse, and it could possibly not help their pain, so that's probably part of it. I guess this whole thing about structural damage in tendon, and I'm probably imaging people a little bit more now. I think, if there's more damage in the terms of partial tears, you're potentially more likely to consider PRP as a regenerative treatment as opposed to cortisone. In my experience, and again, this is not science, is that the patients who fail multiple cortisone injections are usually the ones where they have more structural damage in the tendon. So now, and I think the science is reasonable enough that in those patients you could recommend PRP as your first step in treatment.
John, I know you're doing some PRP as well. I won't ask Paul to comment because Paul doesn't do PRP. But your thoughts on that, John?
I agree with Paul, and I thought it was a good overview, Paul.
Thanks, John.
I think that there's just a couple of things. I always grade the tendinopathy. So there's a 4-grade system that was developed by Jill Cook and I think Craig Purdom many years ago. There's something on our website on that. So I let people know where they are grading. So we don't see grade 1s. So they're the ones that have post-exercise pain, but they're fine 24 hours. And the patients that have really battled just doing basic rehab, even isometrics flare them up. I think Paul makes a good point. If there's enough tendon attached on the footprint, a one-off corticosteroid if there's edema is an option. But again, you let them know that that's not going to fix their problem. And I think for the rotator cuff, which has been a more disappointing area, the patients that have 2 planes of weakness, so they're supra and infra are weak, they don't do as well either. So degree of tendinopathy, and then deciding on how severe they are and whether they can actually load, that will allow you to decide if you want to go to PRP first or not. And the other advantage is a lot of these patients haven't been compliant with their rehab. That appointment, while the blood's spinning, they're with you for 30 minutes. You're going through their exercises. You might take a video or photo of them doing it. They're learning a bit about why their tendon's no good, all that sort of stuff.
All right, thank you. Paul, I know I cut you off at the end there, and I'm sorry about that, but we have to get everybody away on time. They turn the lights off at a certain moment. How do you assess for pituitary dysfunction?
Right. Well, pituitary dysfunction is one of the potential consequences after a concussive impact. So if we understand that the pituitary is divided into 2 parts, a front part and a back part, and the front part secretes 6 different hormones, the back part secretes 2 different hormones. So the easiest way is to just do a screen. If you're wanting to do it as easy as you can, as efficiently as you can, then you just screen for the most common hormones that are affected, which begins with growth hormone. If you've got somebody with long-standing symptoms, then you may need to just assess for all of these hormones that you can, except for oxytocin. You end up screening for about 6 of these hormones. Occasionally, for something like cortisol, which if you've got low levels of, you can feel very lousy, but because it can have pulsatile secretion, a static blood test won't do. Sometimes we have to do urine tests where we collect the urine for 24 hours and we tend to get an averaged result of it as a metabolite over that 24-hour period. Most endocrinologists will be competent doing this, and there are some sports physicians and other people in other specialties who are also comfortable doing that.
All right, Paul, thank you. John, how do you sort of, in layman's terms, if you're talking to the patient, explain the relationship between metabolically based inflammation and how that contributes to arthritis?
Thank you. What I do, I say to them is the way we're wired, our bodies work very differently, and there are chemicals in our body that are good and at times not good. And some people are prone to getting swelling in their joints that develops easily and lingers for a long time. They get inflamed. And these are the types of conditions where we see it. So we see it in people with diabetics, we see it in thyroid dysfunction and so on. And then there are other things you inherit, the autoimmune conditions, some of the chemicals that I mentioned. So I frame it, Daron, in terms of their own personal way their body works, and with that opportunity to go through their family history as well, and how foods then affect them, that then can direct you into that. So more about, it's a curious thing. Many of us, probably all of us at some time, work with sports teams, and we've got players in our teams, men and women, adults, kids, but you see people who just never get injured, and you see those that get injured a lot, you see those that heal slowly, those that heal quickly. I don't think we've appreciated the differences between us, particularly in how we heal and how inflammation works in our body. So getting people to understand what they're like can also affect how they're going to train and things like that later on.
All right, thank you. And I guess this will go to all of the panel. Starting, I guess, with Paul and Annett, have you used PRP or have you referred patients for PRP for nerve root compression or facet joint problems?
Certainly not for nerve root compression. I don't think there's any science or mechanism that would be helpful. I guess facet joint is osteoarthritis. I haven't personally, because I don't inject facet joints because I can't. So I do all my facet joints under CT guidance. I guess I think there's some pain specialists that are doing PRP for facet joint. The principles are the same. It's a small joint. You wouldn't get a lot of PRP in there, but I guess it is a theoretical possibility that it could help. Yeah, I don't think it would help any more than a radio frequency ablation if you've proven that the facet joint is the cause of the pain, though. So.
Not for nerve. With regard to facet joints, I don't treat spines, but I see a lot of hips who have spine problems, and the patients I've seen who've had facet PRP, so lumbar facet, haven't really found it helpful. So there might be, say, 10 patients over the last decade or so.
I don't think I've seen anyone that I can recall that's had a facet joint PRP injection. Yeah.
No from me, and I'd be cautious. The reasons are that it's very difficult to tease apart between facet pathology and nerve root pathology. They frequently coexist. If you've got an arthritic facet joint, you often have osteophytic growth that's in close proximity to the nerve roots, and you get what we call irritation of the dural root sleeve, which is the innervated meninge that goes over the lateral 2 to 3 centimetres of the nerve root after it exits. We know that when we see steroid injections to a facet joint, you often get relief of the nerve root as well, because it is a small joint, as has already been mentioned, and you'll have spillover. It's very difficult to keep it contained within the facet, and I would be concerned about coating a nerve with blood. We can see what actually happens with the meningeal irritation that happens after, say, a subarachnoid hemorrhage, and I think it's more likely to be provocative than not.
Fantastic. Paul, not using the PRP, if someone has a tendinopathy, what do you think the exercise physio rehab program should involve?
Well, look, I think it's key to differentiate between the type of tendinopathy. For a long time, we understand that we have mid-substance tendinopathy, which is often mechanical related, but we're now starting to have an appreciation that what we call the insertional tendinopathies, or the enthesitis, is often autoimmune inflammation. And this makes sense. We often see it in concurrence with inflammatory bowel diseases, psoriatic arthritis, ankylosing spondylitis, these kind of conditions which have an autoimmune heritage. And if you've got an autoimmune inflammation, if we see a tendon, a painful tendon, you've got a lot of bony edema underlying it, then we might want to have visibility that there's potentially an autoimmune component to it, and it's not necessarily a mechanical loading component. A case in point, and it was evident from Paul's slide there with plantar fasciitis being one of the types of tendinopathy that doesn't respond as well to the PRP injections in his hands as the other tendons. And that's because we know that plantar fasciitis is often, it's what we call an enthesitis. We often see an intense bony edema around the base of the calcaneus where it inserts, meaning it's likely to be autoimmune. So if we're trying to address that with exercise, we're trying to use mechanotherapy for a problem that's probably got an autoimmune root cause. So I would just tend to try and identify exactly why, what is the particular pathology in that tendon. I probably should stop there, otherwise I'll go on forever.
So John, what's the trigger for the physio to release the patient and say, now's time for a medical review? Because they're seeing tendinopathies and treating them all the time. So what's that threshold?
Yeah, so your patients that are plateauing at a level that for them is unsatisfactory, so it could be that for them they just have pain each time they exercise, but they don't have the morning stiffness. For those that have, say, stiffness in the morning, and you see that often with elbow tendinopathy, we see it often in the Achilles, I found that is a great predictor of severity and the prognosis. So if that hasn't just gone away despite treatment, and there's a plateau that's unsatisfactory, and let's say you've had 3 or 4 sessions with them over a 2-month period, I think that should be the trigger to say, let's look at some sort of adjunct therapy for them with that. And most patients would be happy with that. By now they've read a bit about it, they know that tendinopathy doesn't go away overnight. You're looking at 3 months, 4 months, 6 months possibly, that sort of thing.
Paul, can you give a parent's PRP to a kid so you don't have to take blood from them?
No.
No.
No, I'm sorry.
It's
probably quite a reasonable question.
They're doing that in surgery. There's a couple of centres that are doing that as well. Personally, I don't believe in that, but it is a serious question.
I guess like an underlying comment, there's very few kids that would need PRP.
Correct.
Yeah, so PRP is degenerative tendinopathy. It's old people. It's me and John and maybe not Paul. And it's osteoarthritis. It's not the other stuff.
Okay, and what do the leukocytes do? What's their role?
I don't know I've got a good answer for you there, other than to show you that the leukocytes obviously play some part in the whole healing cascade. I haven't got the science. Maybe Paul might have something to say, or John, but obviously it seems that the addition of the leukocytes must help in some way the biological cascade to create healing. But that's a good question. Whoever asked
it's interesting.
I bet it was Daron.
It's quite. I'm not sure, but there are people who have significant pain relief from PRP.
Yeah.
And there are others, they're more delayed. So there's quite a variation. I think if you were to put PRP in a healthy tendon, it would be very painful. So I think the more diseased the tendon is, the more desensitised it is. As it's recovering, the injection process is a bit harder, but then they actually respond more quickly. With arthritis of the joint, there is an anti-inflammatory component to that. And I think that's what helps some people. It's really unclear, I think.
And I think it's really important to differentiate between that and stem cells, because there was a double-blind randomised controlled trial done on stem cells at North Shore, and the final advertisement of the study was stem cells very effective at the treatment of osteoarthritis, but they just neglected to mention that it was equally as effective as the normal saline injection. Anyway, Paul, some of what you said about concussion is somewhat controversial in terms of current thinking and sort of certainly what's in the media out there. So what is your thinking in terms of what are the nutritional considerations should we be doing either to prevent the concussion or to try and help the concussion get better afterwards? Can you sort of give us a fairly short
Well,
your thought process
I mean,
on that.
obviously I talked about ketones, so I won't talk about ketones for now, but if we appreciate that the lipid raft and the insulin receptor is central to that pathology of energy dysfunction, then anything that impacts on the lipid raft and can cause insulin resistance is going to be a problem. And there's some really promising research that demonstrates that a very high sugar diet that leads to fatty liver produces a particular kind of waxy lipid called a ceramide, and that ceramide can actually be incorporated into the structure of the lipid raft. Remember, the lipid raft is about 5 times denser in cholesterol than the rest of the cell membrane. It really wants that flexibility, and once we put these ceramides in there, then that further exacerbates the insulin resistance. And this is why people with insulin resistance, diabetics, so on and so forth, they have far worse outcomes from concussion. So we really want to be giving people nutritional advice that's not giving them fatty liver disease. So don't have high sugar diets, don't, chow down, have a soft drink and so on and so forth. So it's pretty simple stuff really. It's just don't eat loads of sugar. One of the other things that's a little more controversial, but I think will be borne out by research in the future, is seed oils. So seed oils contain particular fats that look like cholesterol with a slight molecular tweak. They're called phytocholesterol. They're the plant version of cholesterol, and they don't actually act in the same way that the cholesterol in our body does. And it looks like consumption of these phytosterols can also impact on the structure of the lipid raft and therefore the function of the insulin receptor. So if it's not a bridge too far, it might be worth advising people to also limit the seed and vegetable oils in their diet.
John, that's not a bad segue. If someone's metabolically unwell, they are probably less likely to respond to treatment for their tendinopathies. So what do you approach first? Like, where's the low-hanging fruit in terms of trying to get them better?
It's what philosophers call the existential slap. It's the wake-up call. We often go through life where you have a health moment and you realise, I've got arthritis, or so I'm speaking as someone who's had premature hip osteoarthritis and had my hips replaced, my first one early 40s. And it's interesting when you go through pain and some disability yourself. So the way I approach that is I say to people, how do you think this is going to look over the next year or two? So you project the future, not in a negative way, or have you thought about you're struggling walking, you've got stairs at home, how's your mobility going to be? How's it going to affect your general health? And then you have to approach them holistically. So if with the tendinopathy there is a physical weight issue as well as insulin resistance as part of a metabolic problem, I basically say to them, look, sugar and processed foods are a poison for you. They really are. I'm not saying if you stop sugar today, your pain will go away tomorrow, but what I'm saying is if people follow a low carbohydrate diet and look at safe ways of exercising, so load management, within 2 or 3 weeks, there are weight changes that occur. They start to get encouraged. And I would say about 80% of my patients in that category, because I do get a lot of referrals for non-operative management of arthritis and tendons, as we do. I'd say 80% of them are doing very well over the last couple of years. I definitely did not do this well or knew a lot about this early in my career. So you need to, I think, get them to have that existential slap. And people, you don't want to make them feel guilty, but it's just being realistic.
All right. Paul, what are your thoughts on fish oil, as in Paul Mason?
Well, fish oil is really an interesting substance. There is a animal-derived fish oil contains 2 main sources. One's called EPA, eicosapentaoic acid, and DHA, docosapentaoic acid or hexanoic acid, something like that. And DHA is the main structural fatty acid of the brain. So a lot of the brain is constituted of fat, and 20% of that fat is this DHA. And there's been some very interesting research in children's development where they show that supplementing with DHA actually improves brain development. It literally improves IQ. So we know that it's essential for brains. Now, in terms of concussion, it would make sense that if we're trying to get structural repair, that DHA supplementation would be beneficial. And to the best of my knowledge, there's been 2 randomised control trials looking at that, and they have slightly different results. One shows clear benefit and another one shows benefit, but only up to a certain point. And once you go over 2 grams of DHA supplementation a day, it looks like there's potentially deleterious. And the outcome measures, by the way, we're looking at something called neurofilament light chains, which is another biomarker that will actually be increased if there's structural damage to neurons. So again, more proof that it's a structural damage. And I believe the reason why higher levels of this fish oil supplement were found to be deleterious was that it's an inherently oxidised oil. So the nature of fish oil, it's highly polyunsaturated. In particular, it's got a lysine residue that's very prone to oxidising, basically reacting with the oxygen in our environment. And as you saw from my talk, oxidation stress is one of the major mechanisms, one of the major downstream mechanisms by which structural damage occurs after the onset of insulin resistance. So I suspect that you need to give a little bit of DHA to help provide a substrate for structural repair, but if you overdo it, then more is not necessarily better, but at the same time you'll be getting a higher oxidation load. And we actually know from research that when you ingest oxidised oil, it actually does get incorporated into what we call lipoproteins and ends up moving around your circulation, where it can come in contact with any tissue of the body.
Thanks, Paul. Paul, Annett, I'm going to get you to wind us up here. Patients have had their loading program with the physio, they fail that, they come to you, they get their PRP injection. When they go back to the physio, do they do the same program they were doing beforehand, or do you have to modify the program having had the PRP?
Yeah, I think that's a great question. So I guess my protocol, most people have post-injection pain. So I pretty well tell people to unload completely for the first week so they can just get over that. The precise times are a little bit different for each patient. Most people are sore for 2 or 3 days. Some people a little bit longer, some not quite as much. Then what I'll get them to do is to recommence just some light aerobic exercise and potentially start some of their rehab program, and then usually physiotherapists at about 2 weeks. And then I think it's just back graded program based on their A level of improvement at that time. And it's important to understand that they may not see improvement for up to 6 weeks from the PRP injection. It is a very slow process. Most people, I tell them, might notice some improvement within 2 to 3 weeks, but if I can tell one anecdote, I used to see everyone back at 6 weeks. That was just a standard follow-up time. And I saw one of the local physios had tennis elbow that we'd injected, and I saw him at 8 weeks. He said, if I had have seen you 2 weeks ago, I would have wanted to kill you because my arm has just hurt for the whole time, and I was very, very unhappy with you. And he said between 6 and 8 weeks, it was like someone had flicked a switch and my pain actually went away. So subsequent to that, I've been seeing patients a little bit later. I think, again, this whole protocol about, I'm I guess, a single injector and see how we go. Some people are, you've got to do an injection every 2 weeks or every 6 weeks. I don't necessarily believe in that myself. So I think if you actually just, and most of the literature there, if you look at Jane Fitzpatrick's study and the Peerboom study, they're just single injections and they follow them. And the longer they follow them, the better they get when it helps. So, I think you always have the option to follow up with an injection if they plateau, but I don't think it's mandatory. And as their pain improves, then I guess like you would do with any other patient, you just start to push their physical tolerances with their rehab exercises, and it's a graduated plan to hopefully improvement within 6 to 8 weeks. And then I think it probably takes 3 months. So,
all right, thank you very much.
That was my experience.
So there's just a finish-up message, but before we do that, I'm just going to ask you to thank our panel for their lectures and their comments.